Hello, everybody in the NECADE universe. I wanted to share a little bit about our treatment plan worksheets. This is an ever-evolving project, one that started many years ago. I took many different sources of treatment planning protocols from doctors who have created their own, and I created my version of it, which became Saco River Dentistry's, and then as more and more of the doctors within Saco River Dentistry started using it, they provided insight. And here's the current version. I guess this would be version 1.0 for NECADE. This is just a tool. It's a tool to help you guys find some clarity in the treatment planning process. It has provided an immense amount of clarity for us and hope to share this with everybody else. I see this document changing dramatically over the next 6 months as we start using it as part of our Monday evening treatment planning sessions. Monday morning treatment planning sessions were originally intended to go over treatment plans exclusively with very little focus on foundational concepts and execution concepts. With that said, as we went on, I got the general feeling that there were some basic foundational concepts that needed to be covered, so we spent the next 10 or so weeks going over those, but I want to circle back and start doing more treatment planning on Monday nights. If there are foundational concepts that really need to be covered, I welcome people to send me an email, and we'll either import a video from YouTube that somebody's already done, or we'll try to do a video ourselves and put them into the foundational concepts aspect of the YouTube channel. All right, so here we are, the treatment planning sheets. We currently in our office call it TPP P2. Eventually we're going to be renaming that. The reason why it has a complicated name is because this document exists in a string of documents that lives within a workflow within our practice. Happy to share that at some point. We're really currently kind of rehashing that whole protocol. Needless to say, it's a document among documents. But it's probably the most important document of them all, so that's why I wanted to go over it. So there's 3 different pages, and I'm going to go over what these 3 pages are. But before I do that, I don't know how many people are used to having paper be part of their treatment planning process. Why do we have paper? Well, it comes from the belief that there's a certain segment of the population, our patient population, that when we provide a treatment plan, that treatment plan cannot be done on the fly. In other words, you come in, depending on how your office is set up, you might have a 1 to 2 hour new patient exam in the doctor's column. You may have something similar in the hygiene column. I will say there's an increasing utilization of new patient exams in hygiene. I'm not against that for most people, but there's a certain segment of the patient population that requires a higher level of focus than, a 5-minute doctor exam after the hygienist did all of the charting. I'll leave that up to you, how you use this in your practice, but I'll share with everybody how we do it. So all of our new patients are scheduled in hygiene. We are predominantly a PPO practice. We don't have the financial ability to do a 1 to 2 hour comprehensive exam. I also can't get my head around the fact that all new patients require that level of focus. I think we should be good enough to look at a patient and say, yes, this patient just needs a basic exam, so on and so forth. So we have a line in the sand. It's somewhat gray in nature, but within the practice, we have a general idea of patients that need this extra level of care. So I would say, at least in my hands, a patient that needs more than 1 or 2 isolated crowns, that has missing teeth, that has crowded teeth, that may need ortho, may need perio. Those are complex situations that require a higher level of conversation. If they have a couple isolated class 2 restorations that are required, that's easy to do. They don't need this level of care. But let's just say 20% of the population on a new patient exam presents with a certain degree of complexity that as a clinician, you don't feel you have time to properly identify and treatment plan and make a recommendation all within the allotted time that you have in your busy clinical practice. So what we do is we send the patient to one of our assistants who spends most of her time acquiring this data. Her name is Chantel, and we call that a advanced diagnostics appointment. So we get our perio charting in the initial appointment, we get our full MEL series, maybe a few intraoral photos to build some value on some cracks, but it's not as thorough as maybe some other dentists do. In our advanced diagnostics, for that 20% of the population, they are sent to Chantel for advanced diagnostics. We obtain a full set of photos, very akin to the American Academy of Cosmetic Dentistry photo series. It's basically a full snapshot of the patient's entire mouth. We do an iTero scan. One might argue one may not need as many photos with the iTero scan because the iTero scan is very good. With that said, we still do a full series of photos. We do some videos with the patient speaking so that we can see during phonetic movements where their upper incisal edge exists in relation to their lips. That's very important when you start treatment planning, at least with advanced treatment planning. And then we also obtain a CAT scan. So the patient comes in, it's an hour appointment. We charge somewhere between $300 and $500 for that appointment. We build the value at the previous new patient exam that they have needs that are above and beyond the scope of the new patient exam. We have lots of scripting and terminology that we try to use to build the value in the eyes of the patients. I'm very happy where our practice is in that regards. We spent a lot of time training the staff to get them up to speed with this. The hygienists know who these patients are before the doctor comes in, so they've already built the value. The doctor's just coming in to confirm. But those are all topics for another day. So that patient with advanced needs is sent to the advanced diagnostics appointment. The doctor does not see the patient that day unless they are walking by the room and want to say hi. Really, it's just a data acquisition appointment. During that appointment, Chantel is further educating the patient on the fact that they have needs that are above and beyond that of their maybe previous dental lives. I use that plural. So we're trying to articulate that their needs have now increased to the point where they need a closer look at things. This is to provide contrast to their previous dental experiences. One might argue that we should say that we're better than other dentists and that's why we do this. That opportunity is there for you. I have found that to be more degrading than anything. We have found it very successful if we just say, look, you as the patient have now, in this point in time, reached a crossroad that you need a higher level of focus and attention. We also provide the opportunity for patients not to do this. And what we tell them is if you don't do this, keep in mind that none of our work is guaranteed. We're almost guaranteeing that they're going to have a Friday night fractured tooth where they're going to be in pain. So we're basically trying to foreshadow the future of higher dental problems if they don't go through this. What that entails, the contrary to that, is that if they do it, they will not have a Friday night with a broken tooth. That might be a bold statement to make. With that said, we say something like we drastically decrease the risk that you'll have that. And if we're good at our dental execution, I have no doubt we can do that because many of these patients are going to end up in some sort of full coverage restorations in some form on high-risk teeth. They might end up with a night guard, a mandibular advancement device. We're really changing the environment in which their oral cavity and teeth within the oral cavity live in. I'm very confident. We've been doing this for a long time, and the patients that go through this, we just don't hear from them except for their hygiene recall exams, which is the goal. We tell them, look, I want to see you. I just want to see you every 4 to 6 months, depending on your recall schedule. I don't want to see you on emergency anymore. And that language does very well with patients as you plant seeds and water and fertilize those seeds over time. So Chantel captures all of that information. She then sends an email to the doctor that had requested this set of advanced diagnostic data acquisition. And the doctor then pulls out their TPP/P2 form, this guy here. Now they do this after hours. We are firm believers that for us to do a good job, we can't have the normal distractions of an everyday practice. Most of the doctors that utilize this actually enjoy this process. It's utilization of all of the knowledge that we have acquired in our career and our education to solve a problem, very complex problem for a patient. If you went into dentistry, more often than not, you're going to love doing this. This is more of a joy. So one might ask, am I getting paid to do this? My answer is absolutely, in appreciation from patients that you're giving them a higher level of care. ... Not to mention, you're going to do a lot more complex treatment plans, which end up being anywhere between $10,000 and $100,000. It's not about the money. I have no doubt if you do more of this, you're just going to make more money because these plans are going to be more thorough. Patients are going to feel better about making decisions about things that are more expensive. And at the end of the day, that brings in more money. So frame it however you want. I'm very proud of this. And all of the doctors that have utilized it have seen a drastic increase in their comprehensive care execution, which ends up on their day sheet each and every day. So you sit down 6:30 at night, you have a treatment plan that's ready to be completed. The patient consult is scheduled in 2 weeks. Your practice may differ, but essentially you have that consult ready for you, and the goal is to send this completed form to the patient at their house in the mail or email several days before the consult. Why would we do that? Well, there's a couple different books that we drew inspiration for. One is Emotional Intelligence. Emotional Intelligence is by Daniel Goleman, is the supreme understanding that humans have a rational and emotional brain. When patients are in the dental chair, the emotional brain is the primary driver of their being at that moment. We don't want to talk to that patient. That patient in the emotional state is not a rational patient. But there is a rational being on the other side of that. We're just not talking to that person at that point in time. I like to think of it as percentages. When patients come in the dental chair, especially those that are dental phobic, they're 90% in the emotional state, 10% rational. Then they go home, they have dinner with their family, they're relaxed, maybe had a glass of wine, they're in a very good spot, they're probably 90% rational. Well, we don't have that 90% rational person in front of us. Therefore, when this document first hits their eyes, I want them to be in a rational state, not emotional state. How many times have you presented a treatment plan to a patient in the chair and they just freak out? Well, that's because they were already in an emotional state. So understanding of emotion and rationality and how the human brain works is supremely important to be a good dentist when it comes to treatment planning. We found when we started mailing this to patients ahead of time, it was like an immediate switch went from most patients don't do comprehensive care to pretty much everybody does. And it was that single thing, mailing this form to patients ahead of time. And the reason is they're going to have an emotional reaction. It's okay. But they're starting in a rational frame of mind. They have an emotional reaction, and they have time to process that emotion by the time they come to the office for the consult to have a rational conversation with you. I can't even tell you how amazing this is. There's very few things in dentistry in my career that I'll hang my hat on with such conviction than this. The first time we did this, the patient literally showed up, and this is a true story. Patient showed up and said, "Thank you for this. I have a lot of clarity in what I want to do, and I want to do this option," and it was the most expensive option. This patient I knew for years. I did not think in a million years that they would have chosen anything other than a partial denture. They appreciated the level of care that we're about to show you or share with you. They appreciated that level of care immensely. And we go from being something John Coyce calls the hitman to the healer. It's a concept that's very important here. I might be bouncing around all over the place, but that's okay. You can rewind and listen to the concepts because they're just important. This treatment planning sheet has so much science and evidence behind it and track record. I want you guys to understand it's more than just a piece of paper. John Coyce, for those who don't know, is a world-famous dentist. He worked with Frank Spear many years ago, created his own advanced dentistry continuum up in Washington or Oregon, somewhere in the Northwest. I think he's probably the most sought after at this point. Charges something on the order of tens of thousands, if not over $100,000 of dentist money in order to take his continuum. Many trips out there. But everybody who's done it says his views on dentistry are state of the art. He's kind of a magician with things like this. So he came up with this concept, the hitman and the healer. The hitman is when we're a dentist, we come in and we say, you need a crown. Well, what patients hear when you say that is, as the dentist, I need a new car or I need a new boat. We can fight that perception all day long. We are never going to win that. Those who have tried know it doesn't work. So we have to frame our words differently. And he talks about being a healer instead of a hitman. A hitman comes in and builds the value of the need of a crown without ever saying you need a crown, articulating what's wrong with the tooth and the high risk it has for future problems. And then just sitting still and the patient says, well, I don't want that, what can we do? And then you say, well, we can do a crown, or not even using the word crown, coronal restoration. If they ask, is that a crown? You can say, yeah, that's another name for it. But the term healer versus hitman here is very applicable. When you send this document to the patients ahead of time, you're a healer. You're building value in your recommendations. You're not just giving recommendations. In dental school, we're taught to solve isolated problems, and what we do is we fall into the trap of giving solutions without spending a lot of time on the problems. The flip side of that is some clinicians spend all of their time on the problem, trying to build value in the eyes of the patient, and they actually they have a negative return on the amount of time they spend talking about the problems. That kind of clinician is something we're going to focus on over time. Patients don't really care how much you know. They just want to know what's going to happen if I don't do anything, and what can we do about it, how much is it going to cost, and will it hurt? So we got to focus on those things, and that's what this document does for us. It narrows our focus into the areas that the patient really cares. All right. If you have any questions about this, feel free to email me. I love this document. I can't wait to see what it looks like in 5 years, but I'm proud of how far it's come in the past 5 to 7 years. So you want to start with the chief complaint. Not every patient has a chief complaint. There are patients out there that have no idea how bad their mouth is. So it's there. You don't have to put anything there. But if a patient says something like, I want to chew steak again, you better have that terminology or that phraseology or those words somewhere in your notes. This is a place for us to write this. There's a technique in sales where you use the words of the customer because those words come from their emotional brain much of the time. Not being able to chew steak, that's pretty emotional. If you can't do that, food is an emotional item, you're going to have some negative emotion with it. So writing those words down, understand the chief complaint. If there's nothing there, we also have down here patient desires and goals. Those sometimes are the same thing. I want to chew steak is their desire and goal. Sometimes they're two different things. Sometimes it's chief complaint, I broke a front tooth. Patient desire and goal, I want to rehab my mouth. They're two similar questions, yet they often answer different aspects of the patient's psyche. We're currently happy with these. I could see these changing over time. Feel free to change them as you see fit. Then we have the problem list. This is where we look at the data. So on our CAT scan, I don't refer to the CAT scan if I think there might be a periapical abscess around a tooth. I go through every slice of the CAT scan. I'm not an oral radiologist, but if you're reviewing CAT scans, you should be good enough to understand what's normal and what's not normal. There are times when we refer the CAT scan to the oral radiologist. There is a hot debate in dentistry whether or not you should send every CAT scan to the oral radiologist. I heard somebody once describe it this way. There's things on pans that many dentists have no idea what it is, but they don't send every pan to the oral radiologist. You know, we should be astute enough to look at asymmetries, general aberrations. At some point, we're going to do a CAT scan review. I've done a couple videos that touch upon what to look for in a CAT scan, but we're going to have a very thorough video on exactly what to do when you review a CAT scan. I can review them in 5 to 10 minutes now. It's amazing what you find there. There's so many things that you can use in the CAT scan to build value in the eyes of your patient that you would never get if you didn't have the CAT scan. So when we do the problem list, we're looking at every photo, we're writing down everything. inadequate zone of attached keratinized tissue, Miller class 3 defect around the teeth. Maybe you don't use those terms, but these are problems that may not have active inflammation associated with them, but they're problems. So we go through and we write down as much as we can. At some point, we're going to create a database of problems that are put into categories that you'll have as a checklist that you can go through as a way to remember what are the problems likely to be seen when doing this. In general, you should have 10 to 20 problems on every patient that ends up in this advanced diagnostic protocol. Missing teeth, teeth that are tilted towards the palate and the tongue, scalloping of the tongue, Mallampati 4 of the oropharyngeal space, nasal constriction, high risk for sleep apnea, wearing of teeth, premature contacts, so on and so forth. So there's all kinds of things that we can put in here. Pulp stones that indicate parafunction, so on and so forth. So write down as many as you can, and the goal of Monday night treatment planning sessions is to get really good at, one, seeing problems. As dentists, we understand what a premature contact is, but how many of us have put that into a problem list for a treatment plan for a patient chairside? If you have, it's probably because you've taken a Pankey or Dawson course. But for those of us who haven't, it's easy to overlook things like that. Yet, very important. So we write all the problems here. This is the value building. The better you get at writing patient terminology here, the better the patient is going to rationally understand that they have problems. When we go back to John Coyce's healer versus the hitman is the dentist is trying to get the patient to do something, but the patient doesn't understand they need it. The healer starts with the patient acquiring the understanding, and then as a process of co-discovery, something that came from Frank Spear, through a process of co-discovery, they understand or they come to a solution that solves a problem together. And there's ways of doing that. So it's super important to have this problem list. I've shared this with clinicians before. I tend to see 3 or 4 things, and then they go to the solutions because we're trained to think of solving problems. We're not trained to think, we're not Eastern medicine minded yet in dentistry. We still look for problems and then say, how can we solve it? You've got to spend some time and create the problem list first. Relevant medical issues, things like sleep apnea, hypertension. I would just transfer every positive thing that you have in the medical history here. I tend to focus on things that have a direct relevancy to the oral cavity. You'll find your own style as it comes to that. But I have found the better I get at linking the medical problems to their dental problems in this section, the more value is built in the eyes of the patient, and the more likely they are to do something. So then we come to the treatment planning sheets, page 2. Here is where we come up with some options. There are many dental speakers out there that teach us dentists how to present ideal treatment and ideal treatment only. Then the patient is given the opportunity to tell you they can't afford it, and then you work backwards. That is a technique. I'm not sure if that technique is fair for patients. I think it's a little bit in the arena of strong-arming the patient. With that said, it is a technique, one at which if you're doing it and you're finding success, that's great. We choose a different route, and we want to present that here. So we used to do 5 options. We now call these strategies. This is an older form. Let's go ahead and change that. Because the options are not exact. Our goal here is to create strategies. They're 10,000-foot view options, not specific options. And you'll see why we do this here in a moment. All right, so let me just read this. This is for the patient to read, and we educate them to make sure they read all of this because it's very important. No treatment is always an option. That way we don't have to waste one of the options here. It's good for the patient to know that that's the case. That's also our safety net for the dental board. So if the dental board ever says, well, you never said no treatment is an option, they sign this form. It's right here. It's scanned in the doc center. We can move on. It's just not a recommendation for cases of this complexity. We like using the phraseology of option and recommendation. So we tell patients that's an option for you. So a good example is an all-on-4 for a patient that doesn't necessarily have a terminal dentition. Happens a lot. Patients just reach a point where they're just done with their teeth, but as a dentist, we see a lot of hope in their teeth. We will use the phrase, that is an option, just not a recommendation. You can use that. It is beautiful what happens to the patient's body language when you say it. They relax. They see you as a healer and not a hitman. Because what you're saying is, yes, you can do that, but from my expert perspective, I would not do that if you were my friend or family. It's an option, just not a recommendation. So here we're saying no treatment is always an option, it's just not a recommendation. Then we go on to say the fees associated are approximate, not absolute. So we're going to have estimates here. They're going to be large ranges. Our goal here is not to give a patient a quote. Our goal is to give ranges and let them know that certain options have drastically different price tags to other options. In general, this down here is going to be a removable option and going to be somewhere between maybe $1,000 to $10,000. Option 2, so on and so forth. The fourth option might be a dual arch all-on-4, which goes anywhere between $50,000 and $75,000, depending on complexity and materials and what have you. You want the patient to see these prices in relation to the different options, and I'll come back to that. That's the meat and the potatoes of this document. Actual costs will be done after the specific plan is chosen. So what we're saying here is this is just getting us into the arena. Then we're going to find the seat that we'll be sitting in. It's a term came somewhere in my dental journeys. Some of you may have heard that before. I use it with patients a lot to get them to understand that we're not picking the seat first, we're picking the stadium first, and then we'll find the seat. There's probably other ways to say it. Feel free to find what works for you. These are estimates to guide the patient into the best option for them and their financial ability. These are estimates to guide the patient. So we're trying to get patients to understand what we're doing here. It's not like anything they've ever had before. So I tell patients that paragraph on page 2, I want them to read it a couple times because every word in there is super important. Again, these are estimates. I had to add this. Once upon a time, there were 3 patients within a few month period of time that literally thought these were quotes. They're estimates. Once a tentative option is chosen, more exact costs will be given, as specific numbers can take a considerable amount of administrative effort. Administrative and doctor time. Now that I've read that out loud, I might want to change that to add the doctor time. It's just not easy to come up with an exact cost for something so dynamic as the oral cavity. So we're just trying to get people to understand this is not an exact quote. Many patients, they just have it stuck in their head. They want an exact number. We spend a lot of time early on in the process educating them. We have essays that go before this. We're priming them. When you get this sheet, it's not going to have an exact amount. If you want an exact amount, we will give you the best plan that we see possible with an exact number. And then we just document the heck out of it. But most patients don't go through that when they see how much we care about giving them the options. Then we add on, these fees do not take into account insurance benefits. You can expect that your yearly benefit will be maximized for a case of this size. This was the easiest way for us to tell patients how their insurance money is going to be utilized in one sentence, and it's worked very well. I'll typically say something to the effect of this if I see the patient ahead of time, before I see them for the consult or during the consult. Your insurance plan is a dental benefit plan that is designed to help you with regular maintenance of your mouth. Unfortunately, we're at a point in time where we're not looking for maintenance, but we're looking for a reset so that we can get you to better oral health, which dovetails strongly with overall systemic health. To do that, your insurance company, unfortunately, isn't designed to help you with that. With that said, we're going to use your insurance benefit, and because we're going to be doing so many procedures over the next few years, there's no doubt we can maximize your insurance benefit plan. For example, if you have $1,500 as a benefit in your dental benefit plan, we have no doubt we'll likely use that for the next few years. With that said, the rest of it's out of pocket. This is an opportunity for you to invest in your future. The more stable your mouth, the less problems you're going to have, And we hope to change the trajectory of problems that you've had in the past, which has led you to the frustrating point in time that you have right now. So that's something I'll say to a patient, something to that effect. I'm trying to identify to them that by doing this, we're changing the trajectory of the problems they have. I'll sometimes draw that on a piece of paper. The y-axis will be problems. The x-axis will be time. And then there's a trajectory. And then I draw a line saying, okay, we're going to change that trajectory and head the opposite direction, where there's a decrease in problems or a pause of the degree of problems. It's worked beautifully. Drawing for patients, things like that does help. So here we come. Now it's the job of the dentist putting this together to create the strategies, 1, 2, 3, and 4. Typically, we try to break this up into removable is option 1. Removable will be either complete denture or partial. We used to have option 1 be complete denture, option 2 be partial. Obviously, there's cases where it would lend itself to that, but the majority of the cases lend themselves to kind of a standardization to the strategies. And what we found is there's really not a difference between a complete denture, a patient who just wants all their teeth out versus let's just save 5 of them. At the end of the day, the pros and the cons and the estimate are really the same when it comes to a partial denture versus a complete denture. So we just call this removable options. I might put partials and dentures here. And then pros is low cost. And that's it. Then cons, I make sure to fill this up. Food impaction. They break easily. Tissue changes requiring refittings over time. Less than ideal aesthetics. Requirement of glue. You can go down the list of all of the problems that we run into as clinicians. We don't want patients getting dentures. What are all the things that drive you nuts? And put them into the cons. And then we put an estimate there. May or may not involve extraction of teeth ahead of time, additional dentures, intermediate dentures, and what have you. So option 1 is typically removable. Option 2, a lot of times will be something like crowning select teeth for a really nice partial. So it's a combo case. That might be thrown in option 1. As you can see, there's many different ways of slicing and dicing it. I'm just trying to provide you some guidance on the thought process that has worked very well for us. Option 2 would typically be a combination case. It's designing the mouth so that you have a really nice partial denture, and then getting the patient on a strong recall exam so that all of the food impaction that they're going to see with a partial denture is not likely to cause decay of the hard work that you put in. Option 3 is typically the ideal option. We call that the comprehensive option. Why do we put that as option 3 and not option 4? When I started this, I talked about a couple different books that have been instrumental in us developing this. This concept right here comes from a book called Predictably Irrational by Dan Ariely. It was written maybe 10, 15 years ago. And he talks about how we as humans are irrational. It has nothing to do with dentistry. He's a social scientist that writes things very similar to Malcolm Gladwell, but it has a slightly different spin on it. He talks about how many studies have shown that when given a list of options, the human will almost always not choose the bottom option or the most expensive option, regardless of the value building that you do ahead of time. Well, if that's a real innate, inherent part of our psyche, then I think we as dentists need to construct our treatment planning presentation accordingly. There's a very similar discussion about the distribution of which stalls people choose in public restrooms. Well, if you're designing a restroom and you may want to focus your infection control efforts into a certain stall, I'm just creating an analogy. Well, yeah, you would think it's important. You would want to know that data and you would construct your bathroom accordingly. Well, we know this about humans, that they're not likely to choose that bottom option. Since I've been doing this, I have had countless people literally tell me, this is their words paraphrased, I never choose the most expensive option, so I'm going to go with option 3. It had nothing to do with the pros and the cons, the dental treatment, the science behind posts versus, putting a post in a tooth with an inadequate ferrule and an implant, all those things that we spend so much time on with patients. It literally had to do with where the option landed in this hierarchy of options for the patient. So what we tend to do is we put the 4th option, it's typically an all-on-4. For those patients who need the all-on-4, we will probably add a 5th option that will be a full mouth rehab, saving all of their teeth, which would probably involve saving many hopeless teeth. Well, you can imagine how expensive that would be. It's an option, just not a recommendation. Or it's a strategy, just not a recommendation. So for those patients, we might put a number 5 here and then create this really complex perio-pros solution that we would never do. Patient chooses it, we just say, okay, we need to talk more about this. This was an option, but I wanted you to know all of your options. So I've never had a patient do that. It's all in how you set things up. But the important thing is that the ideal option is not the bottom one. It's the second to last. We do an insane amount of comprehensive care for patients. We never push them. It's just the process that comes from science and psychology. I promise it works. So our 3rd option will be ideal. The pros here will put something like all of your problems will be addressed, not solved, but addressed. Because if you say solved, that leaves them thinking that they're going to be left with a mouth that has zero risk for future problems. If we say we address the problems they have, we've addressed them. The cons, there's lots of things we can put here. And again, our goal on Monday nights is to go over the phraseology that we're going to use here. The cons is time and cost, and that's it. So your ideal plan, the only downside for the patient is time and cost. Some patients don't have the time. So you might end up going with an option that requires less of their time. Some patients don't want to see you 50 times over the next 5 years. These complex cases are complex. They're expensive because you're going to see them a lot. You're going to have temporaries break. You're going to have them come in with a bite change. They're going to have abscesses on teeth that you prepped that you didn't know had problems with it before. It's messy, but it's also highly rewarding. It's amazing what these patients look like when they're done. So time and cost, and then the estimate, we'll talk about that as time goes on. And then the 4th option would be, we can call it the framing option. I believe that's what Ariely calls it in his book. He gives all kinds of examples. You read it, and all of a sudden, as a consumer of goods and services, you're going to realize that this stuff is in front of you every day. You just never realized it. I've had a few associates tell me that this is tricking the patient. I view this as I'm utilizing psychology to make sure the patient choose what's best for them. However you want to resolve this in your head is fine. I feel better about, quote unquote, tricking the patient and seeing them healthy than not doing this and seeing them end up in a set of dentures that will compromise their entire health for the rest of their life. So here's sheet 2. The goal here, again, is to get the patient to understand that there's a range of options ranging from $5,000 to $15,000 to $20,000 to $30,000 to $35,000 to $50,000 to $100,000. There's a large range here. I can't tell you how amazing this is for their understanding about the treatment options they choose. I once had a patient come in and I had removable dentures, pros and cons, and then a cost, and then I had full mouth rehab at the bottom. And what he said to me emphasized the veracity of this approach. He literally pointed at the bottom and said, I'm glad that you did this, word for word, because it struck me so hard. I'm glad that you did this. And he pointed with his fingers. This is during a consult. I would have thought that I was going to get this. So he was pointing to the full mouth rehab for this price. He said, I really didn't understand how expensive treatment could be. Thank you for doing that. He ended up choosing option 2. It ended up being a combination case, 3 crowns, and metal partials. That was 7 years ago. I saw him at a recall maybe 2 years ago, year and a half. He spent a lot of money. Well, he takes care of his teeth now. So there is this whole concept of, it's kind of I call it a disease of dental school. Educators often get us to think that we should never present options outside how much the patients have cared in the past. You see somebody with a terminal dentition, why are you going to give them a full mouth rehab saving their teeth? Because they deserve to know what their options are. So that dental school disease is something I want to talk about, put a spotlight on it. Many young clinicians have worked in the practice and they've had that. I had that once upon a time. I remember 3 different clinicians in my dental school journey that said you should never present options like that to patients that don't deserve to hear it. We're treating humans, and I thoroughly believe they deserve that. After ignoring that and doing it the other way and giving patients the options they deserve, it's amazing how many patients have turned their dental life around. All of a sudden, they're using water picks, they're flossing. I mean, you just have to experience a few of these cases to understand that's the reality of it. Now, 1 out of 5 patients comes along, they spend $50,000 on their mouth and they don't brush their teeth. Do you then penalize every patient after that because of how horrible that situation was? And as clinicians, we feel somewhat guilty that we led that patient down that road? No. In my eyes, that patient made that decision. That patient made the mistakes that led them there, and then they're continuing to make those mistakes. As clinicians, we're not designed, or we're not put on this planet to judge people. That's judging. If you take prior knowledge of somebody's history and use that information to customize the treatment plans they have available to them, that's judgment in my eyes. So you're going to have situations that end up not going the way that you had hoped, but I can promise you through this process and proper education of the hygiene team, where every time that patient comes in, we're really emphasizing how much they had invested. We're using terms like, yeah, you spent $40,000 on this, you might want to brush more. Patients love that stuff. It reminds them. So we're part of their team. We're advocates. We're healers. We're not here to judge. We're not here to make decisions for them. So I digress. I think we get the point of treatment plan, planning sheet number 2. The final page, this is something we've included, we've removed it, we've included it, we've removed it. I strongly think it should be here, and here's why. Many patients, when they see the costs associated with these strategies, simply say to themselves, I can't afford that unless I'm on a payment plan. So that's what's in their head, because they don't understand dental care can be phased over time. Well, what we do is we take the comprehensive option, the option that if we were to present ideal treatment, we then take that and we create a phased plan, and we put some basic costs associated with those plans. When I do this, I really strive to create a plan that spans anywhere between 3 and 7 years. Obviously, 7 years is a long time. But if you have complex ortho, you have complex periodontal problems, if you have a whole host of issues, 7 years is not out of the question if you're going to include some sort of strategy to spread out the payments. What this does, you don't need to be super accurate with this. I used to be very, very precise in the plan, and then the patient would choose options 1 or 2 or 4. The purpose of this is to articulate the following. Phasing is something we can offer you. Let's go through this little paragraph here. This is the recommended and optimal option. Okay, here we're going to call this the comprehensive. Under pros, we call it ideal, so that we're linking the words. I guess optimal, I might want to switch out with ideal. Just use the word optimal in the previous page and you'll be fine. You'll be linking this phraseology with the page before. This is the recommended and optional option. I might put an arrow here, option 3, which brings me to another point. Patients love when you chicken scratch over this stuff. A lot of the doctors like typing. There is definitely a book, I can't think of it off the top of my head, that talks about, it was more about birthday cards and thank you cards and happy anniversary cards about the degree of satisfaction that the recipient has when you handwrite stuff versus just giving them the card and signing it. I think we all know that inherently. We've all received cards that had a handwriting component to it. That inherently says this person cared enough to go find a pen and then spend time in their busy day to write more than just their name, happy birthday, what have you. I think we understand the point. So if you can write little handwritten notes in here, I would recommend you do that. So this is the recommended and optimal option with an arrow, option 3. One that I'd recommend for my sibling, parent, or close friend. I think this is a technique that we're all taught in dental school. Connect their experience and our recommendation for them with somebody that we love and we care for. Works every time. To help alleviate the daunting nature of such a plan, I have broken up this treatment plan into phases. I have done this for you is what this says. This is the phraseology of a healer and not a hitman. A hitman would have come in and said, you need a full mouth rehab, it's going to cost you $50,000. We can finance it for you, see our girls up front. That is literally done in dental offices all around the world every day. We choose a different approach. And if we choose a different approach, we should make sure that patients understand that our approach is one of caring, one of that of a healer. So although phasing is not required, it helps to spread out the financial and time considerations. As we talked about, the ideal plan here under cons is time and cost. Well, let's address that. Let's speak to that. Now, not every patient cares about the time and the cost, but those that do, we can phase this in a way that spreads out that daunting nature for some of those patients. In addition, in many cases, treatment can be spread out over multiple years to take advantage of multiple years of insurance coverage. I don't know why, but including this in your verbiage during your consult is literally probably the most relevant thing that will get them from a no to a yes. Even if the plan is $60,000 and they have a $1,500 benefit, knowing that they can maximize that $1,500 over 3 years is literally the straw that breaks the camel's back towards them saying yes. It doesn't make any sense, but that's the mind of the dental patient when looking at something so significant. When I go into these consults, I try to remember it's obvious to us, it's not obvious to them. This is a very significant thought process for the patient to go through, and it's important to understand that this is very emotional for them. So the next is the column indicated by time between phases will have a time range. The first number is the minimum time needed for healing. The maximum is the maximum amount of time. So right in here, we'll have things like phase 1, disease removal. What's the time that the phase will take, but then how long can you take in between that phase and the next phase? That really helps patients understand that this can be done over time. It is important to know that phasing any of the plans often ends up in overall cost greater than if it's done all at once. Well, that's true. When we phase, we have to lean on things like long-term lab fabricated provisionals. That's probably the most relevant part of the treatment plan that tends to increase the cost. There's just more appointments involved. With that said, it's kind of like when people borrow money. They're going to pay more for that money than if they had the money in their bank account. So if you're going to go buy a car and you pay cash, you pay a different amount for that car than if you borrowed the money over a 5-year period of time. It's the same concept here. Patients, for the most part, have a pretty good understanding of that. So we break it up into 3 or 4 phases. Typically, phase 1 is disease removal, very similar to the phasing that was taught in dental school. The treatment, we try not to get too specific here. Again, the patient hasn't even given you an idea if they can afford a complex plan. The goal here is to just say, remove decay, remove periodontal disease, get rid of broken teeth, improve aesthetics. Because typically part of phase 1, we're going to prep all of the teeth and put them into provisionals. Sometimes ortho is part of this, sometimes ortho is part of phase 2. Don't worry about being exact here. The patient's not going to grade you on the accuracy of this. No other dentist is grading you. This is purely an explanation that their treatment, if they were to choose comprehensive care, can be phased over time. So phase 2, we typically call that the building foundation phase. So we're going to be doing things like bone grafting, putting in implants, anything that has to do with supporting the really nice end result, which is phase 3, which is final rehab, aesthetic reconstruction. There's all kinds of different terms that we use depending on the case. But that final one is intended to describe to them that that's the final part of their journey. And then we might have something called the maintenance phase, which is talking about the fact that no, they can't never see a dentist again. They still have to come in. So we say maintenance. We will see you every 3 or 4 months. Comprehensive treatment plans deserve more frequent recalls. We love seeing the patient every 4 months for non-perio patients, every 3 months for perio patients. Even if their perio is healed, patients with rehabs are at higher risk for issues. It's harder to clean certain areas. There's more embrasures for plaque to get caught in, so on and so forth. As patients get later in life, they might have more dry mouth. So that's the end of this treatment planning process. As my dog is starting to bark, I'm going to go attend to him. But I hope this gives everybody an understanding of what we're going to be doing on Monday nights. We're going to literally do this together as a group, and we're going to try to get as many reps in as we can. If you would like a copy of this, I'm happy to send it to you. Just email me. Just go to the NECADE, www.necade.com, and my email is on there under Contact Us, and then go from there. I hope this has provided some value for somebody. I have no doubt it'll at least provide some consideration for you to revamp your own treatment planning process to something that works better for you. I have no doubt that we can all move the needle in a positive direction when it comes to this, and then see our patients benefit greatly as time goes on. All right, thank you very much.